Okay, you can start the presentation.
Okay. Mrs. XYZ, 67 years old female, who has completed till 5th standard, who is a housewife, hailing from Tirupur, belongs to lower middle class according to modified Kuppaswamy classification. She got admitted on our hospital on 22/7/2023 and got examined 4 days after that. Chief complaints: wound over the upper back just below the nape of neck for past 7 months. History of presenting illness: patient was apparently normal 40 years ago, after which she developed a small nodular swelling over the upper back just below the nape of neck, which gradually increased in size. It got open spontaneously 7 months ago, resulting in the present lesion. It is associated with pain in the last 3 months, which is a pricking type of pain radiating to both her shoulders. Patient also complains of foul-smelling discharge from the wound. Patient is a known case of hypertensive since 2 years and diabetic since 2 months and is on regular medications for the same. There is no history of trauma, no history of burns, skin irradiation, or exposure to any chemicals. There is no history of swelling or ulcer in any other parts of the body. There is no history of dyspnea, hemoptysis, jaundice, abdominal pain, and bone pain. Past history: there is no history of tuberculosis, asthma, epilepsy, and there is no history of previous hospitalization or surgery. Treatment history: my patient is on regular medications for diabetes and hypertension. Family history: here is the pedigree chart, and the patient has a history of sebaceous cyst in her father. Personal history: my patient is on a mixed diet. She has a good appetite. Her sleep is adequate. Her bowel and bladder habits are regular. There is no addictive habits. Allergic history: there is no history of any allergy to drugs or any food stuff. Summary of history: a 67 years old female patient presents with ulcerative lesion over the swelling for past 7 months. The ulcer is associated with purulent foul-smelling discharge since then. She is a known case of hypertensive since 2 years and diabetic since 2 months and is on regular medication. There is a family history of sebaceous cyst present in her father.
Excellent presentation, Ms. Leena. Okay. You look very professional in case presentation. I think. So, what do you think at the end of the history? So, what do you think your case might be?
Sir, at the end of the history, keeping the age of the patient in mind, and she's a 67 elderly female with a swelling over a long period, which was left untreated for a longer period, and it got spontaneously opened. So probably that swelling would be a sebaceous cyst, which would have been opened spontaneously. And now, keeping her age and other factors in mind, it could be probably malignancy, turned into malignancy rather than benign.
How do you say it's sebaceous cyst only?
Firstly, this site,
Okay.
it is in the back side, and it's associated with foul-smelling discharge. Usually, the sebaceous cyst, because of the collection of sebum and other calcareous material, it gives a typical foul-smelling discharge. So it could be that, or it could be secondarily infected, and also her father.
So, and why you give a differential of malignancy here? It's a very long standing, maybe over so many 20-30 years now. And
Yes,
why you think it's malignant?
So it has, in the recent period, it has rapidly grown, sir. Usually the malignancy has got that peculiar feature of growing rapidly in the recent period.
Okay, so let's go back to the first slide.
Okay.
So, why this date of admission and examination are important here? Or why do you consider that taking in the history?
So, especially in my case, since it is ulcerative lesion, on the day of admission, the presentation would have been different. After that, probably after admission, it would have been dressing would have been done, and some modification would have been done to the ulcer site, sir. So when I examined after 4 days, I may not expect exactly how it was before 4 days.
Correct. So always, in any case, date of admission and examination becomes very important, because when you examine the symptoms or the findings may not be the same as the when the patient presented. So there could be a lot of improvement after admission. So that gives a hint to the examiner or whomever you're presenting to, that the scenario has been changed from the when the patient presented and when I examined. Okay, so that's why you, in every case, you have to mention this date of admission and examination. Has occupation got anything to do with this particular case of yours?
Yes, sir. Of my case, it's probably, I think, of malignancy. For all the skin malignancies, the sun exposure, prolonged sun exposure is the major risk factor, sir. So to rule out that, I need to know about the occupation. And also, if there is a radiation hazard, if she's working in a radiation exposure zones, there is radiation exposure to the skin, again, it's a risk factor, sir.
What kind of radiation you mean?
Sir, ionizing radiation.
Okay. Good. Particularly, any examples?
So repeated CT
Common
scans.
one. This is the common radiation which we all get exposed to.
CT scans, repeated scans.
Yeah, okay. X-ray, then
UV radiation.
UV radiation. Excellent. UV radiation, that particularly UVB, right? Okay, UVB radiation is more hazardous. Okay.
It's the 280 to 320 nanometers. UVB is more.
Excellent. So let's go to next slide. See, in the chief complaint, you need not have to elaborate this much. Okay, patient will not tell all this. I have a swelling over the just below nape of neck or upper right, upper left, upper. No, just write wound over the back for 7 months. That's more than enough in the chief complaint. In the HOPA part, you can elaborate or explain everything. Okay, you need not have to be giving so much of description in the chief complaint. Is it clear?
Yes, sir.
Next slide. So patient is having the same that swelling for 27-30 years.
Yes, initially it started as a nodular swelling and it started growing slowly. And
meanwhile, she did not had any secondary changes like infection or any for any treatment taken for that. The same, nothing.
No, sir. There is no. She hasn't taken any treatment for this particular complaint, sir. It was growing slowly over the years. So patient was also not bothered about it much, sir. So she left it untreated. But for the past 7 months alone, it was growing rapidly, associated with foul-smelling discharge and all that. It was bothering the patient much. So because of that, she
what would have happened? What do you think? 7 months ago, what happened exactly to make it like open up and start discharging? You think it is a infection, the sebaceous cyst which got infected and opened up, or because of some friction or because of pressure, it got ulcerated and opened up, or it turned malignant and because of skin erosion, it got opened up. So what are the possibility you think of here?
So when I hear all the answers that you are telling, I feel all are the possibilities, sir. Most likely in my case, it would have probably turned malignant and turned to this, sir. Or it could be because of secondary infection
turning into malignancy.
Sir?
How common is a sebaceous cyst turning into malignancy? How common is it? Is it very common to see like that?
It's not very common, sir. If it's left untreated and
anything,
other risk factors are,
if it's chronic and not irritating continuously, okay, it can result in this metaplasia, dysplasia, anaplasia, and neoplasia at the end. Okay, so even benign conditions, we have to treat it accurately so that the future chances of converting into malignancy can be prevented. Okay, so okay, I think this radiating, you think, does it really any swelling in that, for that matter, in the back, will it radiate to shoulders? Do you think so? Patient will tell, okay, but you should be while writing, no, you should be careful, little careful, which are the condition radiates to shoulders, which are the condition radiates, so you know well, and how it radiates, so you know the logic behind it also. So don't include such things. Okay, patient will tell, but it doesn't mean that you have to write everything accordingly. So why you think what is the reason for foul smelling discharge here?
The foul smelling discharge. Sir, it could be, if it is benign, it could have been secondarily infected and gives the foul smelling discharge, sir. Or if it is malignancy, then The tumor cells and the necrosis will result in the production of polyamides, which would be giving the peculiar false-smelling discharge.
Perfect, perfect. So your patient is having comorbidities like hypertension and diabetes here. So
Yes, sir.
is it contributory in any way in your case?
So in hypertensive patients are more prone for ischemia and ischemic changes, and more often associated with atherosclerotic changes and all that. So because of the poor circulation, there can be ischemic ulcers developing. So that could be the reason, sir. Also in hypertension, there is a specific ulcer called martyral ulcer that can develop, but that is more common in the lower limbs rather than the site which I am presenting. Diabetic patients can develop a diabetic ulcer because of neuropathy that is more for lower limbs, sir. But also there is a glucose-laden tissue which is more prone for infection, which will invite infection, and then it gets secondly infected and it becomes ulcer, sir. Or again, there can be associated atherosclerotic changes, ischemic changes associated.
In this case, diabetes, how it's relevant? In this ulcer or wound over the back, how it is important for you to know about the history of diabetes mellitus?
So the wound healing in general will take, it's delayed in diabetic patients, sir. So strict glycemic control has to be retained for better outcome.
Good. Very good. Very good. And well, if you're planning to operate also, you should control both hypertension and diabetes. Okay. It's all common for all the cases. Okay. What will happen if you don't control the hypertension?
So anesthetic, basically for ulcer removal and all that, anesthetic checkup, all this has to be controlled before giving
Why
general
I'm asking, why even anesthetist is bothered? If hypertension is not controlled, what will happen during intraoperatively?
Intraoperatively, there can be hypertensive, right?
High pressure. So
bleeding.
Yes, if you injure a small vessel also, it will bleed a lot.
Torrentially bleed.
So anesthetist is also bothered about the bleeding, hypovolemia. Okay, patient going into shock. So what about the diabetes mellitus? Why it has to be controlled? So again, for the same reason. Okay, the post-operatively infection rates are high if it's not controlled, or else the wound healing also may be retarded. That's why you need to control diabetes and hypertension well before any surgeries. Or second thing you should keep in mind is drug interactions. Okay, in pharmacology you learned. Okay, what are the drugs? So you should know what are the medicines patient is on before the surgery. Patient is a IHD patient, ischemic heart disease, and the patient is on aspirin, for example, or clopidogrel, and you can't straight away take him for surgery. Okay, because in the blood thinners it will bleed a lot unless it is an emergency. Okay, so all the medicines or comorbidities you should always take into consideration before proceeding further. Okay, and what are the medicines you advise and what is patient is already on may interact each other and may efficacy may differ. So you have to be careful. Next slide. Why did you ask about all these histories here? Why history of trauma?
So trauma it itself can cause traumatic ulcers, sir. I just want to.
In this particular case, traumatic ulcer. Okay, you think this happened because of trauma?
No, so usually trauma doesn't happen to this site, sir, because it's so inaccessible. Yeah.
Okay, no, I will hit from behind. Okay, and it has caused. So what could be like? How can it manifest?
Post trauma, there can be scar. Over the scar, there can be marginal cells.
Anything better than that? Anything better answer than that? When the trauma, there is a hematoma formation. Hematoma. Okay, there could be internal bleeding and hematoma formation. That could have been secondarily infected and opened up, forming an abscess. Okay, now that way you can take here. Why history of burns, skin irradiation, exposure to chemicals?
Yes, burns, post burns, there can be scars, and post burns there can be development of marginal ulcer. This marginal ulcer itself it's a variant of squamous cell carcinoma which is well differentiated. But usually marginal ulcer is not associated with lymphatic spread because of already during burns that lymphatics and all would have been occluded. Skin irradiation I have asked because it is a risk factor for all the skin malignancies in general, be it squamous cell carcinoma, basal cell carcinoma, malignant melanoma. And exposure to chemicals, exposure to coal tar oil and coal tar and cotton oil, all these are specific risk factors for squamous cell carcinoma. And also this psoralen exposure in psoriatic patients post after that there could have been exposure to prolonged sun exposure. Again, it's a risk factor. Swelling or ulcer in any other parts of the body is swelling. I've asked for any lymph nodal spread. If there is any swelling in the axillary region, probably it could have been spreaded there. But the patient will tell it as swelling only, so I just want to know. Ulcer in any other parts of the body.
What other possibility other than lymph nodes, swelling elsewhere in the body? What it infers? Can multiple sebaceous occur simultaneously? Possibility.
Yes,
what is that called? Condition? Multiple sebaceous cysts. You heard me, right?
Yes, sir, I heard you.
Multiple sebaceous cysts. What is that condition called?
So in the scrotum, if it is multiple sebaceous cysts, it rise to a strawberry scrotum. That's when.
Okay. Like multiple lipomatosis. Have you heard?
Yes, sir, that's called Derkham's disease.
Okay.
Multiple sebaceous cysts, I'm not sure.
Gardner's disease.
Gardner syndrome. Yeah.
Gardner syndrome. Okay.
Gardner syndrome.
Okay. So, okay. And yeah, now lymph node is like patient says there is a yes, I have some swelling in the axilla as well. So, what comes to your mind now?
Firstly, I would think about lymphatic spread only, sir, from the ulcer region, or that it could be tuberculous ulcer in the axillary region. Tuberculous ulcer usually.
In this case, only in this particular case. Okay. One is tuberculosis. Okay. Before that, first DD in your mind should be
lymphatic spread.
No. Very benign swelling all throughout, and now since few months there is a outpouring is there. So first thing should be infection in your mind. Okay, infection also can spread to the lymph nodes and okay, infective like reactive lymphadenitis can occur. Second thing is okay, what is that? Lymphatic spread, because since you're telling it's rapidly growing. Third, maybe tuberculosis, because in India, anything and everything can be tuberculosis. Tuberculosis is one disease which will manifest or which will mimic like anything and everything. So in every case, you have to rule out tuberculosis. Okay, you have to consider it as a DD in every case. So that's how. Okay, you have to differentiate the lymph node whether it's an infective etiology or malignant etiology. That's one examination you will conclude that. So why have you asked about this dyspnea, hemoptysis, all those things? They're really relevant here.
Sir, it's not very relevant, sir. Hematogenous spread is not that common, but keeping it as a tumor for completion's sake, I've asked, sir.
See, first you prove that it's malignant. Only then you are not proved that it's a malignant lesion so far. So directly going into metastasis, that too directly into bones, or which skin cancer will spread into bones or liver?
Malignant.
So you have to first prove that the etiology. First in HOPA, first you have to write all about the complaint. Okay. Then its related complications. Okay. Then the etiology.
Yes, sir.
Then that it turns out to be malignant. Then rule out the possibilities of metastasis. Is it clear? Step by step. You can't directly ask the complications even before proving it. Proving the what is the etiology. Next slide. Okay, again, see, very important. The history of tuberculosis. Okay, now this could be earlier he had pulmonary tuberculosis. Now it has spread to the any lymph nodes or any back. Okay, now it is manifesting. Asthma. Why asthma in this case?
So because asthma patients would be on steroids for a long time, and also chronic steroid intake will make the patient immunocompromised, and local application of steroids to the skin also. Because steroid-induced ulcer itself can be happening, or else because of immunocompromised condition that can be accident.
They are more prone for all these any malignancy or secondary infections, etc. Very good. Okay. History of previous surgeries, is it important or relevant here?
It's a previous surgery. So
What
it is
surgeries you
important.
ask? What previous surgery is particularly interested in?
So back spine surgery, not back something. Because in the scar there can be development of ulcer, or else orthopedic surgeries and all demands long-term immobilization, so patient can develop bed sores and also increased changes. And surgery itself could have been done for the similar ulcer itself in the past,
Yes,
and it
that's
could have
more
been
important
recurring.
here. That's more important because see, all those ulcers you told, there will not be any see. Everything, all your whatever you're telling, that should match your index case. You told there was a swelling initially for a long time, then it got burst open. So this pressure sores, will they present like that? Initially swelling and then no, that's ruled out straight away. And the patient tells there is a wound which was there progressive and then it's ulcerated. Then all your what's that bed sores, all those things ruled out. Then in that self, only possibility is recurrence. Recurrence. So you should have asked about history of having similar swelling in the past. That's only relevant. Next slide. Okay, very important. Okay, as I told, to know the drug interaction or whether they're on any blood thinners, etc., which are contradicting for the during the surgery, that you should take a elaborative history and mention it. Next slide. What is the common side effect of amlodipine?
It's a calcium channel.
They come to us many times, to the surgeons, okay, telling that they have lower limb edema.
Okay.
Okay, then straight away we ask, see, in every case, treatment history is very, I am telling is, we start taking all the scans done, RFT done, this unnecessarily. Instead, you ask one question to the patient, are you on any medicines? Yes, sir, I am taking BP tablet. Okay, what tablet? Then they will tell amlodipine, sir, 5 mg. Okay, see, that itself, see, like that. I am telling you the importance of our case performer is so scientifically, so logically prepared. Each question will help you to make a diagnosis. So you can't miss out. You can't leave behind anything. So each side heading has to be taken very seriously and should be made note of. Family history very nicely written here. It has to be written like this in a 3-generation pedigree chart. But why you have mentioned about this sebaceous cyst in her father? The sebaceous cyst, whether it is familial, can it be familial?
The sebaceous cyst itself can't be familial, sir, but there's something called as Gardner syndrome, as you've already told. In that, multiple sebaceous cysts with osteoma and with some this thing can run familiarly, sir. This Gardner syndrome. Sebaceous cyst per se can't be familial, sir. Since patient has told, I.
Okay, good. That because instead of writing many UGs, we have seen writing nothing significant and all. No, you have to write something. You don't know. Which is not significant for you, maybe the most significant for the professor and the patient. Okay, so we have to note something like this. Good. Next slide. Okay, personal history. It's fine. Next. Okay, excellent. This is also very important to note. Allergic history. Next. Okay. So we have two differentials in mind. One, it could be complicated sebaceous cyst. Correct. Second, yes, it could be again benign swelling, which was now progressed into malignancy.
Yes, sir.
That's the two. Okay, we will confirm after examination, please.
So this is my patient.
Okay. Once again, go back to the image. Yes. Now it's very huge.
Yes, sir. Neglected case, sir. She hasn't gone to hospital at all for this complaint. So
they never visited.
No, sir. Since her father had the similar thing,
how she could sleep with this? I don't understand.
She was sleeping laterally. Sir. She doesn't have kids also, so she was like, her husband also died, sir, because of some other reason. She was left alone, so she was not taken care of. Anybody?
Okay. Next slide.
That's it.
Yes, please.
General physical examination. Patient was examined in a well-lit room after taking proper consent and with adequate exposure. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is moderately built and nourished. Her weight is 56 kgs, height is 150 centimeter. Her BMI is 24.8 kilogram per meter square. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. Vitals. Pulse 74 beats per minute. It is regular in rhythm, normal in volume. There is no radioradial or radiofemoral delay. Her blood pressure is 124/82 millimeter mercury, measured in right upper arm in sitting position. Temperature 98.6 degree Fahrenheit. She is afebrile. Respiratory rate 14 cycles per minute. It is thoraco-abdominal type of breathing. Locoregional examination. On inspection, an ulcero-proliferative growth of size 10 into 10 centimeter on the upper back, just below the nape of neck, is seen, which is irregular in shape, which has got irregular margins. The edge is everted and heaped up. The floor of the ulcer contains sebaceous horn, covered with crusted slough and granulation tissue. There is purulent discharge containing a pultaceous material is noted, which is found to be foul smelling. Skin around the growth appears to be normal. On palpation, there is the local rise of temperature and tenderness present. Inspectory findings are confirmed. An ulcero-proliferative growth of size 10 into 12 centimeter located in the upper back, just below the nape of neck, which is irregular in shape with irregular margin. The ulcer bleeds on touch. Depth of the ulcer is 1 to 1.5 centimeter. The ulcer is found to be mobile. The edge is everted, indurated, and heaped up. Floor of the ulcer has got sebaceous horn. Base of the ulcer is formed by underlying subcutaneous tissue, and it is also found to be indurated. Surrounding area of skin of size 0.5 to 1 centimeter is also found to be indurated. Examination of axillary lymph nodes. There is no enlarged lymph nodes. Systemic examination, cardiovascular system, S1, S2 heard. There is no murmurs heard.
Next slide.
Examination summary. An ulcero-proliferative growth measuring 10 into 12 centimeter is seen on the upper back, just below the nape of neck. Ulcer has got everted edge. Floor is formed by sebaceous horn, granulation tissue, and crusted slough. False swelling discharge is also found is present. On palpation, there is the local rise of temperature and tenderness present. Base is formed by underlying subcutaneous tissue, which is found to be indurated. Ulcer is mobile and it bleeds on touch. Surrounding area of size 0.5 to 1 centimeter is also found to be indurated. Provisional diagnosis. It is an ulcero-proliferative growth, which is probably of malignant etiology, most likely a case of squamous cell carcinoma with sebaceous horn as a complication of sebaceous cyst.
Excellent. Please go back. Okay. So, okay, this is fine. But you should know, okay, I will not go into details because it's a short case. Moderately built, moderately nourished. We commonly tend to tell it for all the cases, but it's not like that. Okay. What is moderately built? What is moderately nourished? Because it's an examination. You can't tell subjectively. Okay. There is no subjectivity in examination. It should be under one, there should be some criteria or underlying some baseline should be there. You tell a BMI of 24.8, okay, and you tell it's moderate. No, it's a well nourished.
Well built.
No. Built is different. Built is nothing but the
bony
skeletal framework or the height. That's the build. Nourishment is based on the BMI. Okay, muscle BMI we mainly tell about. So that should match. Everything should match. This built also we compare with the age, gender, and ethnicity, and then we will tell whether it's a short build, average build, or tall build. Like that it should be. Okay, not for all the case conscious, cooperative, moderately built. No. Next slide. Okay, fine. Next. Okay. Now, what do you mean by irregular margin?
So margin, either it can be well-defined or ill-defined, sir. Again, in well-defined, we have got regular or irregular margin. Here, ill-defined margin, I can tell only when there is no, I couldn't make out the boundary of the ulcer. But here in my patient, I could make out the boundary of the ulcer. So I'm telling it as a well-defined margin. Under that, if it is found to be a regular shape like oval or circular, I can tell it as regular, but it is not in my case. So I'm telling it as irregular, well-defined margin.
Okay. And Heaped up and all not required. Averted itself means what? It is rolled out, rolled up or rolled out. Averted itself means, okay, then there is no meaning for heaped up or something like that. Okay. So unnecessary wordings don't complicate things. Floor of the mouth. What is the sebaceous horn?
So sebaceous horn, the pultaceous material of the sebaceous cyst, it becomes hardened to form the sebaceous horns. It is one of the complication of sebaceous cyst, which is present for longer time.
This discharge slowly oozes out and gradually it gets hardened. Okay. And forms like in the path of the discharge that becomes hardened, so that it forms like a horn shaped this thing that becomes called sebaceous horn. Okay. Next slide. What is the difference between the edge and the depth? Is it not same?
So the edge is the junction between the floor and the margin of the ulcer, sir. I think it includes still the floor, but the depth of the ulcer can be even more. Like base of the ulcer, base is the place where the ulcer rests on, sir. So I think up to base, if we take it as depth, the other way is edge, or it's same. I'm not sure.
What do you mean by induration? Indurated?
So induration is the degree of hardness that is associated with an ulcer. In a chronic ulcer like syphilis, tuberculosis ulcer, it could be slightly indurated, and brawny induration is seen in case of an abscess. And in case of a malignancy, there can be a stony hard type of induration. So it helps in rule out many diagnoses, induration type of induration.
Next slide. Okay, you should be mentioning regional lymph nodes. Okay, examination of regional lymph nodes. What is the regional lymph node here? What is the lymphatic drainage of the back?
So into the central and apical nodes of the corresponding sites, into the axillary lymph nodes.
So you measured both the axillary group of lymph nodes and found to be non-palpable.
No, sir.
Next. Okay, fine. Next. Okay, next. Malignant etiology. So, what are the points in favor of this? You say it's malignant etiology.
So, from the history, if I want to start, she's an elderly lady with a chronic history of untreated sebaceous cyst, which she has got a history of spontaneously the swelling has got ruptured and progressed to ulcer. So there is a spontaneous, and in examination, it has got a everted, rolled out edge, and also the base edge and also surrounding skin of size 0.5 to 1 centimeter is found to be typically indurated, which is a pathognomonic sign of squamous cell carcinoma. So, along with the foul smelling discharge, probably if it is due to polyamides, due to necrosis.
One more important feature you are not told.
Sebaceous horn.
No. That's again benign.
Pain.
No, pain is also not a feature of malignancy. It's more of benign infection. Or maybe in a later stage, advanced stage of malignancy.
Nerve infiltration.
Yes. So one more important feature which you had put on inspection, but you're not mentioning here. That is ulcer bleeds on touch.
Bleeds on touch. Yes, sir. It bleeds on touch.
Why it bleeds on touch?
Because of neovascularization that is associated with
very highly vascular. Tumors are very vascular. Otherwise, any benign conditions are not that vascular. Okay, they won't bleed. So that's again. So what do you think? What are the common risk factors for SCC? What are the pre-malignant conditions?
So patients with people with albinism are more prone for and it is associated with xeroderma pigmentosa and human papilloma.
Your answer, I agree. Okay, but there may be so many causes, but causes which are common first, which are related to this particular case next. Then that should come to all these rare things. Understood? When you answer, make it a list in this particular manner. The common causes, common risk factors should be answered first. Then anything related in this particular case, any related etiology is there that you can mention, like that. Next.
So common risk factors such as post burns and treated sedations.
Any chronic
Prolonged sun
etiology? What is the
exposure.
etiology here? What is the etiology here? In your-
Chronic untreated
Hmm.
swelling
Hmm.
that could itself become malignant. Prolonged sun exposure. Human papillomavirus 5, 16, and 18. It is again complicated.
From where does this SCC arise from? Which layer?
So it arises from the prickle cell layer of the epidermis.
This prickle layer. There's something called
The prickle cell layer that
what are
is
layers of epidermis.
so from down to up, stratum basale, stratum spinosum, stratum lucidum, stratum granulosum, stratum lucidum, stratum corneum.
So
That
where
is
is prickle layer came?
the fourth layer, sir.
Which is that? Spinosum.
Spinosum.
Okay, that spindle layer. Okay, or the okay. So that from that layer, SCC usually it develops. Okay. Yeah. Next slide, please. Okay. Wow. Okay. Good. This is brought out. Excellent. It could be another a very close DD is Cox specular tumor. What is this? Please tell us about this.
So Cox specular tumor is an infected sebaceous cyst, sir. Actually, the name Cox specular tumor is a misnomer, sir, because it's not a tumor. It is just the infected form of sebaceous cyst. Here also there will be peculiar foul-smelling discharge. Similar way there will be ulcero-proliferative growth. So this case looks exact, but it is more common on the scalp region, sir. In my patient also is just below the nape of neck, so I kept it as the DD.
Excellent. Okay, that's have you, if it's a malignant, if you think malignant, then you should have mentioned about the staging also, TNM staging. Clinical
Yes,
staging.
I think it is T3, N0, M1, sir. T3 is less than 2 centimeter is T1, 2 to 5 centimeters T2. My patient, it is 10 into 12 centimeters. It's more than 5 centimeters. With not involvement of other structures, so it is T3 and 10. There's no involvement of lymph nodes, so N0, N0.
So you should mention, if you think it's a malignant, you should always mention the TNM staging also. Okay. You know about the Clark's levels?
The Clark's, I remember it like superficially, if it involves still epidermis. I don't remember it exactly. Read about.
What is the staging for other name staging for SCC?
Bristol stage.
Pathological.
The pathological.
What is the classical?
Broader
Yes.
classification.
What is the classical histological features of SCC? Tell me.
So it is the keratin pearls, that is pinkish structureless material surrounded by the this prickle cell layer in a concentric fashion, giving an onion skin appearance. That is the peculiar feature of SCC.
So
the broader staging is
depending on the keratin pearls.
It can tell the prognosis, sir. If there is more than 75% of keratin pearls, then it is well differentiated. It belongs to the grade 1 of broader staging, so it's a good prognosis. Like that, 50 to 75% will come to grade 2, less than 50% like this. It helps in telling the prognosis of the SCC.
Where else you get these keratin pearls? Which other conditions? Epithelial pearls or keratin pearls, where else you get? One is in the face, one more is in the testis. Can you name the conditions? Salivary gland.
Glioma.
And teratoma of testis. Okay, teratoma of testis. So what are the types of SCC, you know? Types of SCC? Mainly 2 types.
So this marginal is a well differentiated form of SCC. I think
the
well differentiated
morphological variations too. Morphological wise, gross.
Okay, yeah, sir. It can be ulcerative or proliferative, or it could be mixed ulcer-proliferative.
Yes.
In my case, it is ulcerative.
Exophytic, or it is a
Ulcerative.
proliferative or ulcerative. Okay, or it could be ulcero-proliferative also. Okay, this is more fits into ulcero-proliferative types. Okay. Next slide is there. You have any other slides? Any investigation?
Investigations.
Okay, how do you proceed now? How do you proceed with this case?
So firstly, I will do all the general investigations followed by specific investigations. So in general investigation.
No. Why you want to do general investigations? Tell me.
So my patient is a diabetic. I just want to know about the serum
That's not the concern now. That's not the concern. What's the concern?
The concern is to prove it is a malignancy or to rule
you're
out
not
that.
at proved only. You still in two extremes. You have one is full benign, one is full malignant. Okay, you have two extremes of diagnosis. Okay, so you're not confirmed. So always tell when the examiner asks you, how do you proceed, or how do you manage this case? First answer, your immediate answer should be, sir, I want to confirm my diagnosis by any specific investigation. That is what? That should be
Edge biopsy.
yes, that should come. All this general investigation or all these things comes later.
Okay.
That's not the concern of primary. First thing is proving your diagnosis is most important. Okay, so first comes the biopsy.
Yes, sir.
What biopsy you want to do?
It is edge-wedge biopsy, sir. The biopsy is taken from the edge of the ulcer and also from the surrounding normal skin. But it's not from.
Why from the edge? Why not from the center?
So because the actively proliferative tumor cells that will be more in the edges, sir. In the center there will be more of a necrosis, so there won't be any.
It's called edge biopsy, a type of edge biopsy, but it's a wedge. Is triangular shaped, including a part of the tumor or the normal skin you take. Okay,
yes,
that's periphery, because proliferating cells are present more in the periphery. Okay, next you can also, after the biopsy, why not FNAC?
FNAC of the regional lymph nodes, I have to take, but there is no obvious enlargement of any lymph nodes, sir.
No, lymph nodes here from this ulcer. Can't you take
FNAC? Yes, sir, it can be taken.
But more chance of this in ulcers and all, more of necrosed tissue only will come in FNAC. Okay, so it's better for go for any ulcers. Better to go for wedge biopsy. Okay, when you suspect mostly the malignancy, or even to look for vasculitis, all those features, it's better to go for wedge biopsy rather than FNAC.
Okay.
Tissue biopsy is always superior. So next year, like you said, swab culture. Okay, any discharges or anywhere there is a discharge, send them for culture and this thing. And why CT? Okay, CT for any lymph node involvement. MRI for local extension. SCC. What tumor is that? SCC.
Sir?
SCC. Squamous cell carcinoma.
Yes, sir.
What type of tumor is that? What type of cancer? It's a systemic malignancy or locally advanced.
Loco-regional, sir, but it can be systemic, but mainly through lymphatics. BCC is more loco-regional, sir, but SCC is also a loco-regional.
It's loco-regional, okay. To the mainly spreads to the lymphatics. Which others? Can you tell me? Give some example for malignancy which will just loco-regional, which will just spread to the nearby lymph nodes.
Sir, there are only two malignancies which are mainly loco-regional, sir, which do not metastasize. That is basal cell carcinoma and the glioma.
That is local, but they don't metastasize at all. Only locally aggressive they are. You told BCC, no?
It's a BCC, sir.
It's local, not loco-regional. There is no spread at all. It's locally. It's called loco-regional. Means it will spread to the only edges draining lymph nodes.
In my case, SCC, sir, thyroid.
Which thyroid malignancy? Why it's
papillary carcinoma thyroid.
Yes. Okay. Papillary thyroid cancer will spread. It's a loco-regional. It will spread only to the what is that? Cervical group of lymph nodes. Next slide.
Last slide.
Okay, so you confirm that it's from the biopsy whether it is benign or malignant. So if
Malignant.
it's benign, how you manage? Or if it's malignant, how do you manage now?
So if it is uh, so if it is benign, I would like to do wide local excision and split skin grafting to close the defect, sir. But if
Why
it is found to
local
be
excision in if it's benign?
local excision,
Excision of the cyst. That's it.
um,
Excision of the, that's nothing called wide local excision for that. Excision of the cyst enough with a margin free of the cyst. Next.
if it is found to be malignant, I would like to know the grading and all that. Like how much is the keratin pulse grading, and alongside, I would like to do the wide local excision and biopsy and split skin grafting close the defect, sir.
How wide is wide? Wide
So
local.
1 centimeter surrounding the 1 centimeter surrounding the here surrounding skin also is found to be indurated. So outside that induration, at least 1 or 2 centimeter has to be taken. So
If it's less than 2 centimeter tumors, you can give 0.5 centimeter. Okay, if it's more than 2 centimeter, up to 1 centimeter of
1
margin.
centimeter.
Old concepts of the 2 centimeter wide margins and all, it's now gone already. Okay, so we leave behind about up to 1 centimeter of margin free of tumor. Okay, that's wide local excision. Then how do you you want to do? What is most surgery?
So most surgery is the microscopic histographic surgery, sir. Here, what happens is it is mostly done for BCC. Also for this SCC also it can be done, sir. The layer by layer, the surgeon dissect out the tumor, and at the same time, it will be studied under the microscope, like whether it is clear, whether it is devoid of tumor margin. Here, the advantages, we can resect limited tissue, but it is more time consuming, sir. Simultaneously, they have to examine, and then again a layer has to be resected. That is most.
I'm not interested in surgery. Patient is not willing for surgery. Okay. And surgeon also, I'm also not interested to do the surgery because it's very wide and it has to be excised and a lot of tissue loss. Then that to granulate or to a flap or to a skin grafting, that's very cumbersome. So what other options are there?
So squamous cell carcinoma is a good radiosensitive tumor, sir.
Excellent.
So we can try radiotherapy, but I would counsel my patient to go for surgery mostly because already there is a sedation on and a lot of things. So if wide local excision is done, she can be completely devoid of that. The outcome will be good.
Otherwise, radiotherapy. Radio for squamous cell carcinomas, radiotherapy is excellent mode of treatment. Okay, many are melts like cheese and they get disappear. Okay, with radiotherapy, many places for squamous cell carcinomas we use radiotherapy. That mainly, like you said, for initial primary modality surgery. But if it's recurrent cases, okay, or in peripheries and all, okay, surgery can be done if it's over any the places where there is operation will cause any major scar or injury to the underlying structure, then we can go for radiotherapy. Okay? Or followed by if it's skin, if you do the surgery, then followed by the reconstructions, flap or skin grafting can be done. Any role of other adjuvant therapies like chemotherapy, immunotherapy, hormone, anything you know? Target therapy.
So chemotherapy, cisplatin,
Based,
all this can be given. And
nowadays, there's something called this target therapies and what is that? Immunotherapies are becoming more prominent or common. You know about any target therapies for SCC? This monoclonal antibodies and all.
Some. I read about it.
It's PD-1 inhibitor semiplimab. Okay, semiplimab. All these are entrance exam questions. Okay. But so many, there are 3-4 PD-1 inhibitors are there. Semiplimab and other things. So you can, that also can be given as a adjuvant therapies here. Okay. So what are the complications if it's a left untreated SCC?
So SCC, if it is left untreated, it will become further more aggressive It will be involving deeper structures more and more. Yes, sir. And it will involve lymph nodes and all that, and it will metastasis to other regions.
So what was done for this case?
So for this case,
The
she's been
treatment?
operated. She's been operated last Thursday. She got operated. Sir. It's a wide local excision biopsy was done, sir, and with the partial thickness skin grafting was taken from her posterior aspect of thigh, and it got closed, sir.
No, you told it was some 1 centimeter deep, and also so must be that. So why you are asking about the depth and the edge, no? So depth is from the surface level. Okay, understood.
Yes,
From the
sir.
skin surface level, whatever you call, that's the depth. Whereas edge, it could be depth or the height. Here, in this case, depth plus the height, whatever the ulcer above the skin level is also counted.
Oh,
Here
the
the
horns.
edge, yes,
Okay. Surrounding. Okay.
yes, no, edge is above the skin level, right? It is averted.
Yes, sir. Yes, sir.
Edge is what between the margin and the floor.
Floor.
So here the what edge is much bigger or much more than the depth. You understood?
Yes, sir. Yes.
Depth is always considered from the surface level. That
Yes.
whatever the extra growth above the surface is not counted for the depth. Okay.
Okay.
So it must be deep. After wide local excision, there was a defect which was deep into the deep fascia or into the muscle. 0.5 to 1 centimeter means
No,
how it
but
was.
on intro of the plastic surgeon, and she was doing it is in the subcutaneous plane, sir. I asked her. It was in subcutaneous. She was telling it is in subcutaneous plane. It's not going deeper. So she has
Just with
put a flap.
the skin grafting, it was
Close.
defect was
Yes.
closed.
Yes, sir.
Good, found, fantastic. Okay, nice, interesting case. What we learn is again how if they are left untreated, even a benign condition can cause so much of complications and needs very aggressive treatment. That's what the like take home message here. Every case has to be diagnosed properly in the initial stages and have to be treated properly.